Hello, I'm Dr. Neil Skolnick, Professor of Family and Community Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University and Associate Director of the Family Medicine Residency Program at Abington Jefferson Health. Welcome to our program on behalf of CME Outfitters. I'd like to welcome you and thank you for joining us for this first of 3 episodes on REM's CMEOCast series. Today's episode is titled, Are You Seeing the Whole Picture? Assessing Pain and the Multitude of Factors that Influence Pain Perception. Today's activity is part of the series on risk evaluation and mitigation strategies, or REMS education, that covers the FDA blueprint, opioid analgesic REMS education blueprint for healthcare providers involved in the treatment and monitoring of patients with pain. REMS compliant education is a critical component of the extended release long-acting opioid analgesic REMS program to provide education for clinicians on safe opioid practices, as well as current regulations and guidelines on treating pain and prescribing opioids in a proper manner. To meet the requirements for REMS, at the end of the activity, please complete the post-test as well as the evaluation to receive your CME or CE credits. CME Outfitters will submit your completed information to the FDA. It's that easy. Watch your email for additional REMS compliant education from CME Outfitters. Again, I'm Neil Skolnick, and it's my pleasure to be here. The learning objective for this program is very simply to apply our knowledge of acute and chronic pain pathways and the underlying mechanisms to our clinical assessment and appropriate management of pain. Let's start with the epidemiology. Pain is one of the most common reasons that people seek medical care. In fact, low back pain, musculoskeletal disorders, and neck pain are 3 of the top 4 leading causes of years of life lost to disability, with an estimated annual cost of over $500 billion. They're associated with some somber outcomes, including suicide, as well as decreased life expectancy. One of the challenges as we think about how we're going to approach pain is that pain is, by its nature, subjective. And what I mean by that is that there's a painful stimulus, but the same painful stimulus applied to each of us leads to a different experience of pain. And that experience of pain is influenced by many things. First, the pain itself. Second, the context. There is this Buddhist saying that pain is inevitable, but suffering is not. And there's a difference between the pain stimulus itself and the way that we interpret it. That is the difference, perhaps, between pain and suffering. And there are many things that determine our experience. One is obviously context. If we're involved in a wrestling match and someone throws us on the mat, we may experience a very different level of pain than if we fall and hit the ground with the same velocity. In addition, obviously, in this obvious example, our suffering is different and the consequences of that fall are different. In that wrestling match, we might get up, not experience suffering, and continue on with our task. When we fall to the ground for other reasons, it might be more difficult to get up. And my point here is that pain exists in the context of many different aspects of a patient's experience. A way to conceptualize this, as in this diagram, is biologic factors, psychologic factors, and social factors. Biologic factors include the susceptibility of a person to painful input. For instance, patients with fibromyalgia have hyperalgesia, and this has been shown in many studies as well as functional MRI studies, to regular or mildly exaggerated painful stimuli. On the other hand, it's not just the biologic input, but it's also what does that painful stimuli mean, or the psychologic factors that are influenced by our upbringing, that are influenced, like I just alluded to, the context in which that painful stimuli is occurring. And then there are social factors. What is our degree of support from those that we care about and care about us? What is our cultural background? We know that in some cultures, pain has different meaning than in other cultures. And the reason why I say this is that we have to understand when we treat patients with pain that this is far more complex than when, for instance, even though this is complex too, we treat patients with CHF or COPD. Our usual approach to many disease states is driven by algorithms where we have some choices, of course, within those algorithms, but we don't need to take into account as clearly and explicitly all the varying inputs to that person's disease state. When we talk about treatment of pain, as we'll see in a moment or two, if we don't take in all of these different inputs, we risk not addressing what's most important to our patient and just choosing medicines without being clear that the medicines that we are choosing are meeting the patient's goals for care. Let's talk for a moment about acute pain and chronic pain. Acute pain is easy to understand. There's a stimulus and there's a response. The stimulus is a painful stimulus and it hits pain fibers and we experience pain. Something happens, though, when people continue to have pain for an extended period of time and over a number of months. And don't worry, we're not going to go over this slide in detail and look at all the different signalers. We're not going to go over cytokines, et cetera. But what is important to understand is the concept of neuroplasticity. And when pain continues past, and it's going to be different for everyone, but certainly past a few months, acute pain can turn into chronic pain, where those pain signals begin to be propagated on their own, divorced from the stimulus that initially caused the pain. And that's essentially central pain. The reason why that's important to understand, of course, is that the treatment for acute pain is very different than the treatment for chronic pain. When we assess a patient, we need to take all of these factors into account. So just like in any other disease state, of course, we want to take a careful history. We want to do a careful physical exam. And we want to make sure that we review, because often our patients with chronic pain are coming in with chronic pain for a while and asking for treatment. We want to always step back and say, do we have the appropriate diagnostic studies to make sure there is not a reversible or addressable cause of this chronic pain? Looking, for instance, with low back pain, do we have that MRI that shows there is or is not an osteophyte or a herniated disc pressing on a nerve? So we do a history, physical exam, diagnostic testing as appropriate. We want to talk to our patient about what their goals are of treatment. We also want to talk to our patient and clarify the level of risk for opioid abuse and dependence. There are a number of validated tools we can use. I think many people use tools. Probably more people in primary care are not using validated tools regularly, both for lots of legitimate reasons. They don't fit into workflow. They're not familiar with the tools. They feel that they can take as good a history with or without the tools. And all of those actually are legitimate reasons, because if we look at the details, at least with some of the tools, as far as how well they predict outcomes, for instance, with opioid risk tools, they're not as good as we wish they were. Nonetheless, they're important to be aware of, and we can choose to use them if we'd like. Tools range from the GAD-7 for anxiety, the PHQ-9 for depression, both for diagnosing depression as well as for following the effectiveness of our treatment of depression. The opioid risk tool a useful tool for predicting the degree of risk that patients have for opioid dependence and abuse. Once we do that, we then begin to put together an individualized care plan. This particular slide, I actually love because I think it encompasses the key point of our discussion today. And for those who are listening rather than looking at the slides, what this slide shows is that there are 4 patients entering the system from the left-hand side of the slide. The physician, the clinician, does a diagnostic evaluation using a biopsychosocial approach, and then together with the patient, makes a decision among the array of management tools that are available, here called the pain management toolbox, which tools to use. Now, this is important because this idea that is actually often talked about in the military, referred to as the enemy gets a vote. Here it would be referred to as the patient gets a vote. When you start having plans, you can have the best plans in the world, but unless you acknowledge that your plans are being carried out in the real world, in the real terrain, and the case of what we do, in the context of a patient making decisions about how well they will adhere to treatment, how well they will carry out the plan, then all we're doing is making plans in a vacuum that we should well expect won't be carried out the way that we plan. The patient gets a vote. In this case, the patient, I think, gets an equal vote to what we as clinicians do. So we want to talk to the patient. We want to set clear goals that we'll talk a little bit more about in our second segment. We want to have those goals clarified with the patient in the different domains that are important to them. A personal domain, how are they feeling? A part of their personal domain is how is their pain affecting their relationships at home with their significant others? What are the things that they're able to do at home? Can they participate in household activities, whether that's cooking, doing the dishes, doing yard work, painting, whatever those things may be? Self, others, and if the patient is working or has work as a goal, how are they doing at work? Is their experience of pain, so that is back to what we were just talking about, both the degree of pain itself, but what that pain means to them, the suffering from the pain, is that impeding their ability to carry out their work goals? Is it impeding their ability to have relationships that are characterized by patience and understanding? So we want to clarify in the different domains of a patient's life what their goals are. We want to then think about how are we going to approach it. And we have a lot more to offer than just medicines, and we'll do a deeper dive on medicines in our next segment. But remember, what we have to offer is medicines. We have to offer behavioral input, CBT, referring someone to CBT, exercise programs often are great for pain, physical therapy, occupational therapy, where appropriate, interventional things like spinal injections or injections of knees and other interventions that may actually fix the underlying pain, and a whole host of alternative medicines, alternative activities like acupuncture, meditation, hypnosis. Once we put together that full plan, then we move to the right-hand side of this slide, which is integrating that plan, having buy-in with the patient. And what we see on the far right-hand side, which is what I think is the critical take-home point of this webinar and podcast, is that while we had 4 patients coming in on the left-hand side of the slide, each with very similar pain syndromes, on the right-hand side of the slide, after appropriate discussion and figuring out the best approach, each of these 4 patients actually has a different plan that they're going home with and for which we will then follow up with them. We want to recognize, and we're currently doing this webinar and podcast in the midst of the COVID 19 pandemic, that the pandemic does create real challenges for our ability to follow up in the office, and recognize that Medicare, understanding this, now allows us and provides payment for telehealth visits. So one option for following up is telehealth visits, so they can be done in a clear, organized way with the frequency that we feel is appropriate for our patient. Finally, goals. I talked about goals. And one of the things that's often helpful is to write those goals that you agree with down in the chart. So in follow-up, we can check in with the patient. How are you doing with regard to how you're feeling about your pain management? How are you doing in your relationships with others? How are things going at work? Being able to discuss the results of our multimodal team-based approach with our patient and the effect of that approach on their domains of pain. I want to thank you for listening to this talk. I want to thank you for joining us today for episode 1 of our 3-part CME series, CMEOCast series. To view additional episodes on pain management, please view www.cmeoutfitters.com. Please also visit the Opioid Education Hub. You'll find other REMS activities as well as a broad range of educational activities and resources for healthcare providers as well as patients. As a reminder, to meet the requirements for REMS, please complete the post-test and the evaluation. That way you'll receive your CME credits, your CE credits, and CME Outfitters will submit your completed information onto the FDA. We hope you'll be able to integrate these pain assessment and management strategies into your clinical practice. Thank you.